Antibiotic Prophylaxis before ERCP for Biliary Obstruction. Good morning. Today, we will review a significant update regarding procedural care in gastroenterology. This discussion focuses on an evidence-based medicine summary of a meta-analysis published by Smith and colleagues in the Journal of Clinical Gastroenterology on September 15, 2025. The study addresses the utility of antibiotic prophylaxis prior to endoscopic retrograde cholangiopancreatography, commonly known as ERCP, specifically for patients with biliary obstruction. Current guidelines often reserve antibiotic prophylaxis for cases where incomplete biliary drainage is anticipated. This new analysis challenges that standard by evaluating the efficacy of universal prophylaxis. The data suggests a need to re-evaluate protocols to minimize post-procedural infectious complications. Study design and patient population. The investigators conducted a meta-analysis of 11 randomized controlled trials. This study design represents the highest tier of the evidence hierarchy for therapeutic interventions. The analysis comprised a total sample size of 2,100 patients, providing sufficient statistical power to detect meaningful differences in outcomes. The mean age of the participants was 64 years. The clinical context for these patients was primarily biliary obstruction. This was evidenced by the fact that most participants required therapeutic interventions such as sphincterotomy, stenting, or both during their procedure. Intervention and control groups. The intervention arm received antibiotic prophylaxis prior to the ERCP procedure. The specific regimens varied slightly across the 11 trials, but cephalosporins were the predominant choice, utilized in 56% of the cases. In most instances, the protocol involved the administration of a single dose of the antibiotic. This intervention was compared against a control group that received standard care without prophylaxis or a placebo. The primary outcome measured was the incidence of post-procedure infections. The researchers specifically looked for bacteremia, sepsis, and cholangitis. Key findings and statistical analysis. The results demonstrate a statistically significant reduction in infection rates for patients receiving prophylaxis. The control group experienced an infection rate of 11%. In contrast, the group receiving antibiotic prophylaxis had an infection rate of only 2%. This difference translates to an absolute risk reduction of 9%. Consequently, the number needed to treat is 12. This indicates that a provider needs to treat 12 patients with prophylactic antibiotics to prevent one case of post-procedure infection. The statistical difference was primarily driven by a reduction in bacteremia, although sepsis was also tracked as a secondary endpoint. Critical appraisal and limitations. While the evidence is strong, there are limitations to consider. The specific inclusion criteria regarding the indication for ERCP varied across the 11 individual trials. While the summary notes the indication was mostly for biliary obstruction, this heterogeneity may affect how the findings apply to non-obstructed patients. Furthermore, the primary reduction in infection was driven by bacteremia. It is necessary to differentiate between transient, asymptomatic bacteremia and clinically significant sepsis. Additionally, while cephalosporins were the most common agent used, 44% of patients received other antibiotic regimens. This introduces variability regarding the optimal medication choice. Clinical implications and recommendations. These findings are highly relevant for hospitalists and gastroenterologists. The data suggests that the current practice of limiting antibiotics to patients with expected incomplete drainage is likely too conservative. A single dose of a cephalosporin generally carries a low risk of allergic reaction or resistance development and is low cost. Given the number needed to treat of 12, the benefit of preventing infectious complications outweighs the risks associated with a single dose of medication. The evidence supports adopting universal antibiotic prophylaxis for patients undergoing ERCP for biliary obstruction. This approach appears superior to attempting to predict which patients will have incomplete drainage. Based on the Level 1 evidence and the large effect size, this recommendation receives a strong evidence-based medicine rating.